তুষার ভাই জাস্ট 10 সেকেন্ড পরের থেকে কথা বলা শুরু করলে হবে, জাস্ট 10 সেকেন্ড।
আচ্ছা, কামরুল সাহেব শুরু করতে পারি?
ইয়েস।
Assalamu alaikum and good evening, dear participants. Welcome you all in today's ECG study group session. Today is our 41st lecture and topic is ECG for fun. And is that magician, physician, our respected Professor Dr. Rafique Ahmed sir will deliver the lecture. Before the start, I request to say a few words about Rafique Ahmed sir, and then we proceed. Wadud sir.
Good evening, everybody, and Assalamu alaikum. With a heavy heart, today we are going to start the program. Our friend, mentor, and one of the founder director of the study group, Professor Atahar Ali's mother is still on ventilator. It's 2 weeks going on, and we are very much unsure what will be the end result. So, with a heavy heart, we are continuing. Today, Rafique Ahmed sir is going to present again about arrhythmias. I think all of us who are attending these sessions know very much about Rafique sir. So I'm not going to say anything more. Just I can say this much. He has taught us a lot. And he has shown us how perseverance, determination, integrity can actually bring about results. That's how he has become the founder of electrophysiological study in this country. Let us all learn from his wisdom, learn from his experience. Rafique Ahmed sir, the stage is yours.
Good evening and Assalamu alaikum. So I'm going to talk about, this will be basically, we'll look at ECGs and we'll discuss them. It's not going to be a formal lecture. That was the plan. But I'm going to talk about EKGs that constitute kind of emergencies, not the ones that are very obvious. So I'm not going to do those. So I'm not going to talk about obvious ventricular tachycardia. I'm not going to talk about acute myocardial infarction, but there are ECGs that are emergencies, but we can miss them. And that will be my topic today. So these are the conditions, ECG conditions that require emergency care. One will be symptomatic sinus bradycardia. Somebody comes with heart rate of 30. Asystole pauses, symptomatic 2 to 1 heart block, complete heart block. And the tachycardia will be atrial flutter fibrillation with rapid ventricular response, supraventricular tachycardia. Ventricular tachycardia fibrillation, I'm not going to touch these because these are very, very obvious. Acute myocardial infarction, that is very obvious when I'm going to talk about, but electrolyte abnormality is something that is subtle, but ECG can give us clue. And if we find those, we need to make sure that the patients are taken care of. So I'm going to start with one ECG. This is a patient who came to the hospital with syncope and put on telemetry monitor. And I have a few choices here, and we can do some.
Sir, should we start the poll?
Let's give it maybe 10 seconds and let everybody look at it.
And poll for 20 seconds, sir, or 30 seconds?
What did we do normally? 30 seconds, right?
30 seconds, yes, sir.
Yeah.
Okay.
So I request the audience, all of you, please try to answer. Please remember that answering anything is correct answer because that's what you are thinking. And then our job is to rule in and rule out the diagnosis. And that's how we learn. And secondly, I like when we do things right, correctly, we don't learn. We learn actually when we make mistakes. because the one that I'm doing correctly, that means I'm just maintaining my knowledge. But the one that I'm going to make mistake is where I'm going to learn. So please make.
পোলিং একটু সময় বাড়াও, এত জলদি শেষ করো না।
So please answer the questions. And there are 85 participants. I hope all of you will answer today. Or at least
increase the time of polling.
Okay, sir. Increasing to 50 seconds, sir.
Good. I'm encouraged by the number of participants. That's great. So the answers were multiple. There was sinus rhythm followed by complete heart block, sinus rhythm followed by sinus arrest. Majority said atrial fibrillation followed by atrial standstill, and few said atrial fibrillation slow ventricular response. Please remember, all of them, all the choices are partially correct everywhere. Choices, when we give multiple choice question, the way to put the choice says question choice will be that all the answers should be partially correct. So you want me to do it, or Wadud or Dr. Shafique or Jamil, you want to do this thing?
Shafique, do you want to comment? Shafique. Jamil bhai, will you be commenting, please?
Sure. So in this ECG
Your
strip,
sound is not good, Jamil bhai.
in this ECG strip, now is it better?
Yes, definitely.
Okay. This ECG strip shows initially there is irregular heartbeat with undulation of the baseline, and there is no definite P waves. And there is also electrical alternance in these complexes, and followed by a long gap, there is no electrical activity, and then one junctional escape and one followed by a ventricular ectopic. Then it seems to be there is a small P wave and a normal complex. So most likely my choice is atrial fibrillation followed by atrial standstill, then junctional escape.
Okay, good. I think that's that. But let's look at one person said sinus rhythm with complete heart block. What is the point for him? It is possible that he thought this is the P wave.
Yes, sir.
And maybe there are other P waves. But if this were complete heart block, I would have seen P waves all over the place, followed by ventricular beat. The fact that I did not see any P wave here takes that thing out. Sinus rhythm followed by sinus is similar methodology, that if we look at this preceding tracing, it's irregular. And even though these waves look like P wave, I don't think they are P waves. I have the benefit, but sometimes, fibrillation waves can look like P waves, but that irregularity takes it out. Fourth will be atrial fibrillation with pause. That is possible. However, if you look at this top strip, you can see the fibrillation wave so nicely, and then there is no electrical activity at all. That means what happened? The patient was in atrial fibrillation, the atrial fibrillation stopped, and there is a conversion pause of about 8 seconds, followed by junctional beat, a premature beat, and possibly by this time the P wave is taking over, and I don't have any further strips. So the diagnosis correct answer is atrial fibrillation followed by atrial standstill, then junction escape beat. And the others are wrong answer, but those are partially correct answers. And this is same one. If we have a little bit of longer strip, you can see here, you can see it better. And this is the same one repetition that you can see how irregular this RR interval is. So that's what it is. Question is, now this patient, why does it constitute emergency? Now, if this patient is in the telemetry floor, came with an episode of syncope, and he does it, or she, this is a female patient, she does it with a pause of 8 seconds. Am I going to put a temporary pacemaker in or not? That is the question. So that's a tough decision because the pause happened with conversion from atrial fibrillation to sinus. And let's say this is happening at 7 p.m. And after this, patient has developed good sinus rhythm. I can choose to put a transcutaneous pacing pad on the patient and monitor overnight, and then next morning make a decision whether the patient needs a permanent pacemaker or not. But the problem will be if this patient after half an hour goes back to atrial fibrillation, then you definitely will have to put a temporary pacemaker in. Why? Because next time when he will convert, may have a longer pause. And Wadud, any comment on this?
The scenario that the patient has syncope, that means, particularly in our country, I would put a temporary.
Okay.
And at dead of night, you cannot be sure that all the personnel are there and they can put a temporary pacemaker immediately. And we don't have transcutaneous pacing. That's a problem here.
Okay, so that makes sense. So I agree with that, that we have good transcutaneous pacing and the nurses are well versed in this thing. And we will put this patient in a unit where it will be one-to-one nurse follow-up. So if I put the patient in CCU, one nurse will be following that patient. So, and also the Wadud point is very important because patient came with syncope. So it is possible that patient was going back and forth. So in the context of Bangladesh, you put a temporary pacemaker in and the next morning make a decision. And as I said, this was 7 p.m. It will be much easier to put a temporary pacemaker than in the middle of the night. Thank you.
So we have
The question is,
in our hospital.
sir, if I put a dual chamber permanent pacemaker, how can I be sure that the atria will be responding nicely?
Okay. The question is, if I put a dual chamber pacemaker, but I'm sure by this time the sinus had come back. So if there is sinus P wave and the patient is in sinus rhythm at the time of implant, you can check it. You can check the capture, number one. The problem will be if there are very few rare patients that have atrial standstill, and only way to find out, you put a atrial lead, and if it captures, then you leave that atrial lead. Sometimes you will find patient that there is no electrical capture of the atrium at all. In that case, there is no point of putting atrial lead at all. If the patient is an atrial fib, then you cannot check the atrial lead. Sometimes we will put an atrial lead without testing. We'll check the sensing of the fib wave. We will check the impedance. That's about it. And majority of the time it works out fine post implant. Thank you. So
in that case, the patient who having this atrial fibrillation and pause, the mode switch should be on for a dual chamber pacemaker. When the patient goes to the atrial fibrillation, it's switched to VVI.
Yeah. So for the audience who do not understand complexity of pacemakers, if we put a dual chamber pacemaker in and program dual chamber mode, what can happen during atrial fibrillation? It will track the atrial fibrillation page at a very fast rate. And new pacemakers in America, all the pacemakers have mode switch. I think even in Bangladesh now,
yes, sir.
I don't think there is any pacemaker without mode switch anymore.
Dual
So what
chamber,
it does,
all dual chambers have mode switch now.
yes. So what the dual chamber pacemaker will do, as soon as it will sense fibrillation, it will go to VVI mode or DDI mode, more so. This is another patient, ejection fraction 25 to 30%, comes with syncope on July 28 at 17:26 p.m. And this is the ECG, the first ECG.
Did the patient have history of chest pain, sir?
No, no chest pain. It's a known cardiomyopathy patient which came with syncope, and this was the first ECG. No chest pain at the time of presentation. I think this is good. Wadud,
Yes, sir.
I'm very happy. I mean, this is not an easy ECG, and majority actually answered it very nicely. And it doesn't mean that others are wrong. And shall I comment, or any one of you want to comment on this?
Sir, ECG, one DD should have been pacing.
Yeah, I didn't want to make any more complex. That's true. What Wadud is saying, maybe paced rhythm should have been a differential diagnosis.
Yes, sir.
So the question is, what is this? Sinus, it is right bundle bunch block. If you look at lead V1, small r, big R, so right bundle. Is it sinus? I cannot see any P wave. I have long rhythm strips, so I cannot see any P wave anywhere. Second, so it is not sinus rhythm. So definitely that is right bundle bunch block. So this answer is partially correct. Ventricular tachycardia is not correct. First of all, it does not fulfill the tachycardia criteria. So that if it is a ventricular rhythm, then it will be an accelerated idioventricular rhythm.
Yes.
Because it's a wide QRS. But the thing about accelerated idioventricular rhythm, why this looks like typical right bundle. First R bigger than the second R. And so it is most likely right bundle junctional rhythm with right bundle by old inferior and anterolateral myocardial infarction. So, I mean, you can still debate, are you right? Because can it still be VT? So let's look at what happened to this patient. I'm going to give you another ECG. This was the same day, a little bit later. That was at 5 some p.m. This is at 8:43 p.m. You will analyze this ECG, but look at this pattern doesn't change here at all. So what is it now?
This is sinus. First review.
So this looks like.
Let them answer, right? We'll give the poll again. One of the things that I did not add, patient has marked left axis deviation.
Exactly.
Does it, because inferior MI can also cause left axis. But if you look at this ECG now, I did not, on purpose, I did not put that choice just to make it congruent. But if you look at here, there is actually a small R wave in 2-3 AVF. So it's more like right bundle with left anterior fascicular block. So let's see what the answer is now.
extreme axis deviation.
Yeah.
Sir, with the history of syncope,
Yes.
is not this patient a very good candidate for pacing?
Well, that's what we're going to come. So why should we take this so seriously about this? So the sinus rhythm with right bundle majority say be ventricular tachycardia. Again, the thing against ventricular tachycardia is it did not fulfill the rate criteria. Tachycardia should be heart rate over 100, any tachycardia. So whatever ventricular it is not tachycardia.
So
And
there
of
is
course,
also, prolongation of chair interval.
now there is P wave.
Yes, sir.
So now we have P wave. We can see consistently in the rhythm strip below P QRS, P Q, and there is 1-to-1 relationship. So now this is sinus rhythm. I didn't put the PR, but there is first degree AV block.
Right, sir.
And right bundle buncher, left anterofascicular block. So it is sinus rhythm with right bundle will be the most logical choice here. So let's go back, and if the QRS did not change at all, this ECG versus the previous, and that supports our junctional rhythm diagnosis, because somewhere in the junction it came conducted normally to the QRS.
Sir,
So
again, sir, again, the last choice, accelerated idioventricular rhythm, we do not see that without the setting of acute coronary syndrome.
Exactly. I mean, it is rare.
That's why I was asking for chest pain.
No, yeah, good. Thank you. And also the other thing that the ventricular beat here in V1 is initial R smaller than the second. If it were other way around, I would have thought as a ventricular rhythm. Now, what happened to this patient? We're going to come to the management and what should be done. And Wadud alluded to the question, should this patient get a pacemaker? Right bundle bunch block, left anterofascicular block, first degree AV block with syncope. That's one. Why should we take this patient very serious? So this is the ECG next day, 28th of July, and next day, 29th of July. I want, what is it now? Same patient.
Now this has become left bundle. Changing bundle block.
Yeah, let's see what they say.
Exactly. Sir, just have a question. In the first ECG, if
let them answer, we'll talk about.
No, sir,
Yeah, go
not
ahead.
this ECG.
Okay,
Not
good.
this ECG, sir. Before
Yeah.
that.
Yeah.
So in exam, if the ECG is given and the answer is that 4, without mentioning any other thing, only sinus rhythm with right bundle branch block. So if someone answered that,
Yes.
if someone answered that, will he pass or will he be get negative
Okay.
mark?
No. You see, if I sinus rhythm, right, the second ECG, right?
Yes, exactly. Sinus rhythm where P is evident, RBB is evident, and there
Sinus
is
rhythm,
nothing
right bundle
not
branch
mentioned.
block should be an acceptable answer. It's an incomplete answer, but none of us are complete in life. So a partially correct answer should also be accepted. And by doing the diagnosis, he or she is not endangering patient's life. So there should be no negative marking for that. If that person calls that totally normal ECG, then I will probably give him a negative marking, because then we are missing something which can be serious or catastrophic for this patient.
So as the polling progress, the examinee might ask, sir, there is no mention of first degree heart block or bundle branch block or
Yes.
axis deviation. So I thought that is the right answer.
Okay. So now again, the choice is A. Nobody said A. Right? It's not right. That's good news, because nobody thought that this is right bundle branch block anymore. Sinus rhythm with left bundle branch block is a choice, of course, but there is no P wave before any of the QRS complexes. So left bundle part is correct, sinus rhythm part is wrong. Accelerated idioventricular rhythm is a possibility, but if you remember my talk on ventricular tachycardia, exactly the same way we can differentiate between a left bundle and a ventricular rhythm. And this one does not fulfill that. It's more of a typical left bundle type. It's not typical, but it is a left bundle type. So the diagnosis is junctional rhythm with left bundle joint block. And that makes this person a very serious patient, because this is a patient who is going into left bundle, but who going into left bundle was right bundle left anterofascicular block, will be at extremely high risk of developing asystole if something happens to this patient. So if this patient comes in at night, I'm going to put a temporary pacemaker in this patient and consider pacemaker. Now, why did this patient pass out? What will be the cause? Any comment from our panelists? So that's my.
There are two possibilities, sir. One is that there is a complete heart block, stochasm. And the second possibility is that patient has very low ejection fraction. That could be ventricular arrhythmias.
Yes. So this patient, I do not know what happened in real life.
If this sir, do I need to put a dual chamber ICD in this patient?
Yes. So the question is, if the ejection fraction was normal, I will put a dual chamber pacemaker in. This patient's ejection fraction is 25 to 30%. The obvious cause is intermittent complete heart block, but it can also be ventricular tachycardia. This patient should receive a dual chamber defibrillator. But for emergency care, this patient should be kept in the unit with a temporary pacemaker in place. Number two, also considering the possibility of ventricular tachycardia so that we have defibrillator available to resuscitate patient not too far away. Please remember that we must always remember what can go wrong. And if we remember that, then we can have necessary arrangements. We don't have to think in the middle of the night, what happened to this patient? If I thought that this patient may go into VT, and that applies to any procedure that we do. When we do procedures, if we remember what can go wrong, then we can have mental preparation to work on that. And that's why every time I do a procedure, I go with my team and tell them these are the things that can go wrong and be ready for it. Like when I'm going to put ICD in this patient, we will not do it with a temporary pacemaker because we are used to it, but I will recommend that there should be a temporary pacemaker, number one. Number two, when I put the ICD lead, at the time of putting the lead in, patient can develop ventricular tachycardia. So if we are mentally prepared for it, we will not panic when this happens. And it is so important to remember those things. Any questions from any audience or anybody?
Sir.
Yeah.
Is this patient a very good candidate for CRTD?
Well, that's what I was about to come, that now we have low ejection fraction. I'm sure patient has heart failure, even if they don't have heart. Once you start pacing the right ventricle, you will actually worsen the LV function. So the ideal device for this patient will be a biventricular defibrillator, or at least septal pacing. If we do septal pacing, then you can create a narrow RQRS complex. So yes, definitely biventricular defibrillator. Okay, so we'll move to the next one. This is the same patient, you see, 1 year ago, again had the same left bundle type. So the patient originally had left bundle, and then before presentation develops also right bundle joint block. It's interesting. So how can somebody survive with both bundle joint block? And that brings us to the definition actually has changed, that what we consider complete left bundle joint block actually is never complete left bundle joint block. It is rare. There is some conduction. That's why when the patient developed right bundle, there was conduction, and that was going down through the, I don't think we should do this one. This one we'll skip this question part. So this is old. So this patient is sinus. So it is not, even though we call complete left bundle joint block in electrophysiologically, it is not always complete left bundle branch block. Okay, this one, and we'll have a poll.
আপনার কালেকশন সাংঘাতিক স্যার।
No, these are our patients. So I keep collecting ECGs, and some of them I did not keep all the notes. I try to keep notes on the clinical background. Like this one, I didn't remember. It's 2004. I don't remember whether the patient is syncope or not.
Sir, perhaps this ECG is one of the most beautiful ECG. And nightmare for the interventional cardiologist.
Hmm. So because it is difficult to put all the choices to the audience, my request would be that please don't ignore when you report. Do not ignore the ST segment, T wave. Those please report those because those are important and relevant to this. Who will do this? Dr. Shafique or Dr. Jamil? Dr. Shafique? Yeah.
Sir, thank you, sir. Actually, this is a bit difficult. This is so far I can guess because if you see, but it is definitely right bundle branch block with left anterior fascicular block. So choice is 3 or 4. And why not? But what would be the junction rhythm or ectopic atrial rhythm? Here, the fourth QRS complex in the rhythm history. Fourth QRS complex, where P wave is a bit different from other P waves, and RR interval of the fourth and fifth RR interval a bit longer than the previous RR interval. So here there is a bit question that this P wave is different from other P waves. So this is ectopic, whether it is an ectopic atrial rhythm could be. So this is my choice.
Yeah. Sure.
Can I make a comment, sir?
Yes, please do.
Let's start with lead 1. The first wave, we're seeing the P wave. It's a P wave in there, but it's negative. So look at AVR, there is a positive one. So there is something amiss in there. Now let's go to the rhythm history. We see the P wave, we have 2 types of P wave. First, second, third, and fifth. These 4 have similar P waves, but which is not looking like the usual sinus P wave. And the 4th one is the upright P wave, but that's also PR interval very short. That also do not look like sinus P wave. So this is an ectopic rhythm. And again, as already Shafique has pointed out, the patient has bradycardia with right bundle branch block with left axis deviation due to left anterior fascicular block. So I would go for 4.
Yeah. So the question is, the answer of junction rhythm. Yes, it is possible that this is junction rhythm with a retrograde P wave. However, if it were junction retrograde, the P wave would have been closer to this. This is a little too far out. So this is driving this QRS. So this is ectopic atrial rhythm. And then of course, we have right bundle branch block, left anterior fascicular, and the ST wave changes, whatever it means. Question is what to do with this patient. I mean, what we try to do here in America, I mean, my practice, that I try to avoid temporary pacemaker, because once I put the temporary pacemaker in, it increases the risk of infection. More so in Bangladesh, because patients have to arrange for. So, I mean, if it is necessary, depending on the clinical scenario of this patient, you have to do what is right. You don't want to panic in the middle of the night. In that, so putting a transvenous pacemaker is not a it's a reasonable choice. What we do, this patient came to the hospital at time is hiding. If it comes around 2 o'clock, we'll do the pacemaker same day, unless there is reason not to do a pacemaker. What will be the reason? If this patient is on big dose of beta blocker, calcium channel blocker. And then we'll have to wait and see if the medicine washes out and the heart rate comes back. Then we'll wait. But this is the 88-year-old female. So this is the same patient. Again, same patient. I mean, I'm just putting this.
Can I add something, sir?
Yes, please.
This kind of issue we often find with the patients with end-stage renal disease or severe renal failure who are having electrolyte imbalance and metabolic derangement. They also present a correction of the electrolyte, it comes back to sinus.
Yes, so that is something that we have to keep in mind. So whenever somebody comes like this, I think that brings us to history. History is so important. Wadud asked me the first question, did this patient have chest pain? That's the clinical history. What was the patient? Is the patient taking any medicine? Does the patient have renal insufficiency? We're not just pointing, the ECG is helping us. And if we think there is a possibility of electrolyte, we need to look at the electrolytes, make sure that the electrolytes are fine. So those are important. So same patient, and I have put few choices there.
The juxtaposition of this ECG with the previous ECG, that actually shows the evolution of the disease process. Yes. And how should progress into clinical decision. It's exactly. A beautiful example, sir.
Okay. Excellent. I think majority again are in the right direction. So Wadud, I think great job in teaching ECGs for the whole group. So this is the same patient. I'm going to talk about this. So if you look at what Wadud was talking about evolution, this is 21 July 2004. And let me go back. And next month, 1 month later. So, sorry. What's happening here? Sinus rhythm with atrial premature beat, of course, is a choice. In that case, I'm making an assumption that this is the sinus beat, this is the premature beat. That is not true because here there is no P wave. So that is clearly a junctional beat. Then I'm looking at a different way. Okay, let's consider this as the sinus beat and this sinus beat. That brings me to a diagnosis of sinus bradycardia. And then there is a pause with a beat which comes. So I think this is the escape beat rather than this being the premature. So that brings us sinus bradycardia with junctional escape beat. And of course, right bundle branch block, left anterofascicular block. Now, so if I look at this, why is this sinus? If you remember, Wadud mentioned the old one was negative, AVR was positive. It has changed. In lead V1, it is biphasic. This is clearly sinus beat rather than an ectopic beat that we discussed before. So this is basically an evolution. And how about this beat? What I think is, even though there is a P wave, this is an escape beat because the PR is so short that they just came on time. So this is still a junctional beat. It just looks, it happened at the same time. Please note one thing, that T wave changes have significantly changed. You see, this is July and this was August. Significant wave changes, and that has to be addressed in our evaluation of this patient. Why this patient has this T wave change? Is this patient having any chest pain, had any chest pain? Is there any coronary artery disease? We need to, just make sure that we are not missing something. All right, Wadud, any comment on that?
Sir, that's why I was talking about, whenever we actually, I was that day collecting some ECGs from a patient who presented with acute inferior MI, complete heart block, and then gradually progresses into second degree AV block, first degree heart block, normal sinus rhythm. And the progression of the disease and the completion that can be produced with a particular disease, if you have the evidence in the ECG, that actually give you a story, and you can remember the whole thing much better, understand the whole disease process much better.
Yes. So in ECG, we use the term a driver. Who is the driver? Here, the driver is sinus. That we have to identify. We did the reasoning. So please understand the reasoning. And if you have questions, you can always ask one of us. You can text it to me and to us, and we'll discuss more. I didn't put any question. This is basically sinus bradycardia and the first degree AV block. Same patient. What date? Patient comes 5th of July, June 2005, 5:38, and then same day develops this again. If you look at this one, what's happening here? Let's look at this 2-bit. There is no P wave before the QRS complex, but there is a P wave here, and there is a P wave here, and there is a P wave here, and there is a P wave here. I think what's happening in this bit, that there is no sinus. This is a junctional bit with a retrograde P wave. Why retrograde? It's a very sharp pointy in V1, and the relation is consistent, more or less. There is some variation, and this bit probably is a bit. It's either retrograde going a little early, as I mentioned, or another P wave, ectopic P wave. So basically, this is a junctional rhythm with intermittent sinus beats or retrograde P waves. So this one.
Very nice response, sir.
Yes.
It was
So
a bit easy.
I'm going to start with ventricular tachycardia. It is tachycardia and it is a white QRS tachycardia. So it's a possibility that this is ventricular tachycardia. However, two things go against it. One, there is irregularity. Ventricular tachycardia is rarely irregular. I'm not saying always regular. It is rarely irregular. Secondly, if you look at V1, small r followed by a big R. So that's typical right bundle pattern. So irregularly irregular with typical right bundle that goes against. And of course, if you have any other doubt, you can go back to our lecture before and use the criteria how to differentiate between VT and SVT with white QRS. Sinus tachycardia with sinus arrhythmia, right bundle branch block, even though I put a choice there, it looks like a little bit like group beating, but there is no pattern to it. If you measure, put a caliper, you will find that each RR interval will be irregular in this. And that will also go against Wenkiba, because Wenkiba, there is a pattern to it. The first R interval, and then there will be gradual change. So it will not be irregularly irregular. So the diagnosis is atrial fibrillation with rapid ventricular response with right bundle right block. This is a simple bread and butter patient, but this can also turn into, so we always put these patients on telemetry. And of course, we put rate control medicine. And anytime we put rate control medicine, we need to watch out. If you remember my first patient that converted had a long pause, I will take a detailed history of this patient, if the patient has syncope or not. I don't remember the patient's history, but this is what happened to this patient. This was 1st of March at 9:02, and this is around 10 o'clock. So I have these few choices. And this 1, 2, 3, 4 that I have put is the time in seconds.
Excellent.
Yeah, that's good. I will start with choice 1. You see, irregularly irregular. So even if, first of all, I have the previous ECG. Well, let's forget about the previous ECG. There is irregularity in the RR interval. And this may look like a P wave, but I don't see any P wave here. And then when there is this flat line, there is no P wave in it. As I mentioned before, if it are complete heart block, I'll see P waves interspersed. And same is true for sinus rhythm with sinus arrest, because here there is no P wave, there is no P wave, it's probably fibrillation. And then, so question is atrial standstill, then escape it, asystole. So we have this, there is line, and maybe there is a P wave or artifact or junctional escape or ectopic, and then there is a long asystole, and then rhythm actually comes back. Over here, you can see the QRS complexes. And this is not the correct. With pause, these are similar thing I'm saying. So to be fair, I think I'll take both correct, but this is the correct answer. And again, this patient, this is a 10-14, unless there is any reversible cause, like if this patient was on very high dose of diltiazem or something. But as an 82-year-old, you have to seriously entertain possibility of putting a pacemaker. And then until that is done, this patient should have a temporary pacemaker in place to manage. And if there are drugs that is causing slowdown or this asystole, that should be helped. So, same patient. And after that, pause.
বাবাকে একটু পানি দে না মা লিসামনি কি করে নামাজে Very good answers. Don't you think so? The distribution is very nice. Dr. Shafiq or Dr. Jamil, can you comment on this, please?
Sir, if we look at the rhythm strip, there are same morphology QS in preceding every QRS complex. And there is a little bit different kind of bit which is premature in position. That one is the 6th bit. And morphology of the QRS complex is little bit different, wider and different from the other complexes. So it seems it may be a ventricular original ectopic bit. And there is also QSR pattern, RSR pattern in lead V1 with a small r initial and r dash is taller. And this goes in favor of right bundle branch block. So I go with the option 2, sinus rhythm with ventricular premature bit with right bundle branch block.
So only part is that if we look at V1, it's totally positive. And so question is whether it's an ectopic rhythm or if the lead position is correct, I should have seen a biphasic wave here.
Yes.
I did not. The other part is if you look at lead 2, there is an initial negative component in the P wave. If I could expand, sometimes I will expand them, but also same is true here. There is a dip in the baseline. And here in lead 1, I can't see very clearly anything. AVR, of course, is negative. AVL is kind of funny. So that's why I thought possibly it's an ectopic rhythm, but it's a possibility. But both are very close choices. Now the part, whoever answered 2 to 1, it is true that is a P wave which did not conduct. But as Dr. Jamil mentioned, this is a premature beat, which is defined morphology. And what it did, it penetrated the AV node and caused concealed conduction and made the AV node refractory. So this P wave could not conduct. If you time it, it will be exact. So this is the same morphology P wave. So it's basically a ventricular premature beat with, and then whether it's sinus or ectopic, these are question of debate, but I felt more like an ectopic, but sometimes you can never know because the sinus node is a very long structure. And within the sinus node, the wave can move up and down. If you go in the lower part of the sinus node, which is basically 1 inch from the top. So if a wave comes from lower part of the sinus node, that can come with a different morphology. Okay, so let's look at the next ECG. This is just for the sake. Again, this is a similar ECG to the one before, that there is sinus beat and then pause and junction beat. This is very much classic for sick sinus syndrome, and most of the 68-year-old female, unless they're on some kind of medication that causes this, they will end up needing pacemaker. Not necessarily this patient, if they come to the hospital, I'm not going to put a temporary pacemaker in because never a syncope. It's just dizziness. I can keep them in bed in telemetry monitor and then make a decision about pacemaker implantation. So this is a patient came with syncope with a heart rate of 38, but he was on big dose of labetalol, 200 milligrams BID. And this is the ECG. What time do you want us to stop? Please let me know. Another 5 minutes and done.
Sir, continue for another at least 15 minutes. We
Okay,
are
fine.
enjoying it.
Okay.
Yes, sir. The explanation should be proper and completed. As you have already discussed these rhythm abnormalities, I think if you stop suddenly, it will disheart the audience.
Okay. So,
Sir, in the meantime, sir, there is a question that
yes.
the difference between sinus arrest and atrial standstill. What is the difference
Yes.
between sinus arrest and atrial standstill?
Yes. Sinus arrest will be something that happens and then your sinus comes back. But if you have ECG today, there is no P wave activity. You do tomorrow, there is no P activity. That's atrial standstill. Basically, no P wave activity at all. So that's basically a chronic condition. Those are very rare patients, and those patients it's difficult to pace the atrium, even if need to.
And as the poll goes on, I just wanted to ask you, sir, another question. That is, in our part, the frequent practice is not able to do pacemaker with complete heart block. Many a time they get propantheline and theophylline just to increase the rate, atrial rate.
Yeah.
And many of the patient may say that they are doing fine. So electrophysiologically, how you explain the thing and the rationale of that thing?
You are talking about complete heart block patient?
Many of the patients are complete heart block or wish to want AV block.
Yeah. Well, we don't.
And those who
we
are
don't
not
use
affordable.
Yeah, I
those
know.
who can't afford. Okay.
No.
Sir,
But
the
you have to
response is good.
understand that many patients with complete heart block will do fine without pacemaker.
Yes.
And not thanks to those medicines. It's just, that makes doctors happy. There are certain medicine which I call good feeling for the doctors, not benefit to the patient. And this is one of the situation. So I mean, if the patient cannot afford pacemaker, I mean, cannot afford it. I mean, not that they're going to drop dead. So we'll come back to that. So this one, nobody said sinus rhythm with 2 to 1 heart block. That's fine. Sinus rhythm with
Good response, sir.
intermittent 2 to 1 heart block. Yes. Okay, let's come to that. So if you look at this, there is no P wave. It's all fine wavy line, which is very much consistent with fibrillation. So there is no sinus rhythm in this. I mean, you can look at every lead. And so atrial fibrillation, slow ventricular response, right bundle, left anterofascicular block versus this one. And left anterofascicular block is the consistent diagnosis because this is what to do with this patient. I'm not going to put a pacemaker in this patient immediately. I always tell people that if when you see these pauses, it can be maybe the beta blocker slowed down or that is underlying heart block. That's the possibility. Yeah.
Was the patient had any history of syncope?
Yes, came with syncope.
Okay.
But then the patient was on labetalol 200 BID. That's a pretty big dose, right?
Yes, sir.
So we decided to stop the labetalol. This is May 38, 2007. And this is the ECG next day.
It's in the sinus rhythm, sir.
Sinus.
Yeah, no, let them answer.
Okay.
Sir, towards the end of this session,
Yeah.
please, if you enlighten us with the with your views regarding that use of those propantheline and theophylline, in a that will be a very helpful for all the physicians, junior, especially junior physicians.
Yeah, so we can ask comment of our panelists also what we think about it.
After finishing this ECG, sir.
Sure. Okay. Yes. All right. So this is actually the one ECG that we miss most, and anybody can miss it because the rate is 48. That's bradycardia. That is prolonged PR interval, first degree AV block. Right bundle blind block, left anterofascicular block. Obvious choice. Anytime I see heart rate in the 40s with this kind of right bundle, left anterofascicular block, left, I always try to see if there is a second P wave I'm missing. And that's always my practice. So if you look here in V1, there is a P wave. There's a P wave. This T looks funny. It's kind of unusual shape for a T wave in. And if I look back in other places, it's tough to say. I mean, you look at lead 1, this T wave looks funny. So here, you see, it's a little bit of biphasic wave exactly like this. So that it always tells me that this is 2 to 1 heart block. And this is something that we're going to miss. Now, look at this. same patient. If you do not, I am glad that Hafiz is not here. Hafiz will always tell me you are making things up. We don't have to answer. Look at this now. It's more visible. Same patient. See, P wave. So this was actually 2-to-1 heart block with right bundle branch block, left antifascicle block. So if somebody misses this one, no shame on them. Look at this here. There is no way I can tell on this. If I look at this part, there is no way I can tell this is 2-to-1 heart block. Only when I look at lead V1, it gives me this suspicion that there is something missing here. And even after that, I'm going to look at other places. Can I confirm it? And this was at it was at 8:34 p.m. And then this was at, so this is a different patient. This is another time, and look at this P wave. So this was 2-to-1 heart block. And now the patient is off labetalol and 2-to-1 heart block. Right? Yeah.
I have a thing. Whenever we think that sometimes the T wave looks like P wave.
Oh God, Hafiz is here.
Sometimes it looks like the T wave is like P wave.
Welcome.
So we can map, right? We can map like with the calipers and
yes,
see the timing.
Yes, yes. But Hafiz, the problem is this one. You know, when you have this one, if you have a rhythm strip with lead AVF or lead 3, it will be almost impossible to see this because there is nowhere to put the caliper. I can put the caliper, but it's only when you look at carefully at other leads. And the question is that you have to have a degree of suspicion. And even with this, I will try to reconfirm at other times. So just keeping an open mind that heart rate in the 40s with bundle branch block, always think of 2-to-1 heart block. Am I missing a P wave? And that's what is important. From now on, Hafiz is here, so I have to be careful what I say. I cannot make up stories because he is going to challenge me. Hafiz, nice that you could join us. Have you been listening to us and keeping silent? Hafiz?
Yes, yes.
Hafiz nice silent watcher.
Okay. So this is another one. I think we are getting late, so I'm going to just do this. Again, if you look at this heart rate 36, and this one is a little bit more obvious. There is a P wave here and there is a P wave here. You see this one. And there is a P wave. Again, even with that, like this one, if I look at this lead, you can say, well, is this the E wave? And that's when Hafiz mentioned caliper. Put a caliper on it. If this times out exactly same, more likely a P wave than an E wave. So this is a patient who presented with short. And then why I put this in ECG emergencies, because those ECGs, if we miss and the patient develops asystole in the middle of the night, we have problem. So these are subtle ECG changes compared to acute MI or VT. And so this is a patient who came with exertional shortness of breath. And these are an important group of patients. We see quite a bit of these patients come with this kind of symptom. And if we could answer this, please. So one of the things about this patient is that this patient did not come with syncope. This patient came with shortness of breath. So the clinical context of any patient with any ECG is very, very important, that we take a good clinical history on any patient.
The responses are interesting.
Yes, I think that's a good response. Majority of the physicians are answering it correctly. And others are also participating, which is important. I think it's important to participate. One of the things that we do in training, Hafiz is a training program director, we don't try to trick people into giving wrong answers. We teach reasoning. We try to elicit what you know. And then if you don't know something, we try to correct it, and a repetitive thing, right, Hafiz? Okay. So I'm going to comment on this. Sinus bradycardia with right bundle branch block. Sinus bradycardia right bundle left anterior-fascicular block. And then I did a little on purpose. There is actually left axis deviation, right? Wadud, do you agree?
Yes, sir.
Yes.
Yes,
And
sir.
there is left axis. So the last, by default, I just left it off. Question is it sinus bradycardia with E wave or 2-to-1 heart block? Again, the same theory comes in that if you look at lead 2 rhythm strip, looks like an E wave. You can put a caliper. But if you put here, you see this E wave cannot be that sharp. It's the P wave. So it's basically a 2-to-1 heart block. And this is something that we are going to miss. Sometimes we will get patients with exertional shortness of breath, normal coronary arteries, right bundle left anterior-fascicular block. We will put them on treadmill. And if we do a regular treadmill, you will find that as the rate increases, they go into 2-to-1 heart block, and that can explain their shortness of breath. I think I'll do one more ECG and then we'll stop there. This is a patient. I think we need to do this because this patient was kept in the telemetry for a few days before any decision was made.
That's interesting. Sir, this one is a gem.
Yes, this is actually this patient was left in telemetry floor for a few days. It's amazing. I think I'm feeling very good about this program. Look at the answers. Especially the
Very
last.
hard,
Huh?
Very good response.
Yes. So is it junctional bradycardia? It's a possibility because there is QRS complexes, right bundle branch block, and no immediate P wave. But there is a P wave here. And that points to a diagnosis of sinus bradycardia with first degree AV block with right bundle branch block. Sure. And at a sudden look, first degree. But if you carefully measure it, this is different. And then as you move, you can see that there is a P wave here. And if you then put P to P, you'll find that, let me see if I did the timing or not. If I did timing, it will be easy. Okay, look at this here, that these are the P's. You see there's a P wave here. So there is no P wave to QRS relationship. So it's complete heart block. Now, between the two, is it a ventricular escape rhythm or is it a junctional escape rhythm? That's important. Why? Because if it is junctional escape rhythm, the patient is less likely to go into asystole as opposed to ventricular escape rhythm. How do we know that? Look at the lead V1. It is typical right bundle. That means the impulse originated from the junction conducted with a right bundle pattern. And junctional beat is more stable than ventricular beat. If it were ventricular escape, it will be different morphology. So it will be either, this is the typical right bundle morphology. So that's it. So the correct answer is complete heart block with junctional escape beat rhythm with the right bundle. So this is important to know. So what happened to this patient? Look at this. This patient was left on the telemetry. This is 9th of April. And patient was left in telemetry floor until developed torsade because the QT was long and it is bradycardia dependent prolongation of the QT. Patient develops torsade and then everybody looks at. So why this is an emergency ECG? First of all, it is complete heart block. Secondly, even if the patient didn't have syncope, we can end up with a rhythm like this. And if it happens in the middle of the night and there are no physician or defibrillator nearby, very close by, it can literally kill the patient. So that's so important that this was picked up. And then, of course, the patient gets a permanent pacemaker, and you can see atrial cells ventricular pace rhythm. I'll do one more ECG, which is important for all of us to know and notify this ECG, because if we find this ECG, we have to make sure that it is taken care of immediately.
Rafique bhai, a quick comment.
Yes.
These two EKGs, like right bundle, left axis, you showed, and then 2 to 1. And then importantly, you mentioned shortness of breath. And I tell the fellows that even if you don't listen, when you see this kind of EKG with clinical presentation of shortness of breath in the elderly, often they have aortic valve stenosis, or often they have significant conduction system disease and cardiomyopathy. And then rushing to pacemaker without doing a thorough evaluation sometimes can be a problem. And then it's embarrassing almost to do all these things without working up.
Yeah, no question about it. I mean, the question is that listening to the patient, examining the patient, there is no alternate. And then we will always get an echo before we put a pacemaker in. For two reasons. We want to look at the valvular structure, which not immediately affects, but also LV function is important. Is there a possibility of ischemia? Not that fixing the ischemia will reverse the pathology, but it is important to look at all those things together. It's not just looking at a single point.
So this is the ECG one should remember and keep in the memory always.
Yes, yes, no question. Okay, Hafiz. Hafiz. Hafiz, are you with us? So, I mean, this is the ugly looking ECG. As soon as I see this ECG, I will first make sure that the paper speed is correct. Because you can mimic this kind of ECG, you can look at, and if it is a 50 millimeter speed, that's a speed problem. Second, is the patient having chest pain or not? And then, because some of the severe ischemia can do all these funny looking ECGs, and this patient had none. Then what we have this almost sinusoidal QRS complexes with prominent Q wave. This is an emergency, because if we don't pay attention to this, it will determine whether the patient is going to be alive or dead. This patient had a potassium of 10 when it showed up. It's one of the highest that I have seen. And so look at this. Next, the patient got calcium and insulin calcium, and look at even though a patient's potassium was 7.5, the QRS has almost normalized after that. So this is one of the important situations that you have to look at. Look at this, and I think we should stop here. It was interesting, and thank you all for your attention.
Thank you, sir.
So thank you very much for your deft touch, what we say, the very subtle and very exquisite presentation. These are the presentations that gives insight of ECG learning to all of us. There's a great learning session, sir. And before we go further, sir, I repeat the question again. The protocol of giving propenthelin and theophylline in complete heart block or second degree heart block patients, does it at all give benefit to the patient, or is it just something?
So the question is there any benefit of giving any medicine? If you take a patient with complete heart block and I'm going to show you something. This patient.
Sorry, sir, I may bother you, but this is the frequently encountered situation in our country.
So this patient, heart rate of 39, junctional escape. If we stimulate the junction, the heart rate may go up a little bit. If it is ventricular escape, there is no medicine except dobutamine that will increase the rate. So we do not use theophylline or propenthelin, any of these drugs. And there is no data on this. If the patients cannot afford a pacemaker, those are not alternate therapies. The other thing I have seen, patients with sinus bradycardia getting those medicines also. There is no need to treat sinus bradycardia because patient Bjorn Borg, the biggest tennis player in the world, has a heart rate of 38. So you cannot. So if somebody has sinus bradycardia, we need to make sure to correlate the symptom with the arrhythmia. Patient feels tired. Then look at other times. At other time, patient is feeling fine, still the heart rate is 45, and sometimes feeling dizzy, heart rate 45. Other times, not dizzy, heart rate 45. That means the dizziness is not caused by the bradycardia. So we correlate those very carefully. It is not our practice to use this medicine at all. We don't use. I don't know if Hafiz has any comment. Hafiz is gone.
So can I add something?
Yes.
Using propenthelin bromide or theophylline gives no benefit to the patient. It's my clinical experience. And it's just like the patient says, I am fine, as because there is some placebo effect of every medicine. So patient thinks that I am taking medicine, so I am fine, and he restricts his daily activities so that he do not get much demand on the heart and don't get any symptoms.
The other thing is that just because there is nothing available does not mean we will use something that is not proven to be beneficial.
Yes, sir.
And there are a lot of circumstances it happens. I mean, we have patients with cancer, terminal cardiomyopathy. We cannot do anything. And we have to be frank with the patient about that. That look, there is nothing can be done for this. And that's also important as a physician. So unproven therapy use is not something that we should be practicing. And it gives a bad habit for us. We should use science. Wadud, any
Thank you,
comment?
sir.
No. Okay, thank you.
Actually, what I tell our patient, actually this is just giving comfort to our mind, but it doesn't work. You need this. This is the electrical problem. You have to solve it electrically.
Exactly.
And sir, one important message I think we get from this presentation, whenever we see us or whenever we call sinus bradycardia with rate below 50, we should always look to exclude 2:1 AV block.
Especially if there is bundle branch block.
Yes, sir.
If there's underlying bundle branch block, that becomes only. If it is narrow QRS, then it is less likely for that to happen. Because, yeah, but always keep an eye out for that.
Although it is time constraint. Hello, can you audio?
Yes.
Yeah, me, Professor Abdul Salam, sir.
Yes, Assalamualaikum.
Kevan aছেন, sir? Hello.
Hello, Jay, hello.
And the lecture today I enjoyed very much. My question is remdesivir-induced bradycardia. People are using salbutamol, this theophylline as well.
Class নিচ্ছি একটু পরে কথা বলবো আমি ক্লাস নিচ্ছি পরে কথা বলবো
Regarding this, because remdesivir is a analog of that adenosine, so it causes bradycardia. So in that case, people are using these heart rate increasing drugs like salbutamol, theophylline, and procainone.
I have no experience with that. I mean, if the patient is in the hospital, and then again, you also have to look at, is this bradycardia causing any symptom? That's important. Not all bradycardia will cause. If the heart rate was 60 and drops to 45, and the patient's blood pressure is fine, patient is hemodynamically stable, patient is not complaining of anything, there is no need to increase the heart rate. That's what I look at. Sometimes we'll use isoprenaline short term in the hospital while the patient is there, or we are waiting for a definitive therapy, but we don't use any long-term rate increase medicine. There was only one rate increase medicine that was tried in the early 90s called Zemoterol. And after that, nobody has ever tried to make one because that increased mortality. And that study was stopped. Thank you.
I was talking about not hospitalized, home treatment with remdesivir. It happens to my wife. That's why I'm asking this question.
Oh, yeah. No, I mean, there is no, data on these drugs, but these are all stimulants. You can always say, look, I want to use for a short period of time, if it is symptom, but we cannot make it a practice pattern without any really data based on science. Because then what happens, we start doing this favor to patients. Here and there, we all use anecdotal treatment modality based on our experience, but those cannot be recommended as a guideline or regular therapy for the common population.
Thank you, sir.
Sir, can I share one case, sir?
Sure.
So a COVID patient having morbid type 1 heart block first, then patient was shifted to CCU in COVID cubicles. And later on patient developed 2:1 block. Right now there is in 2:1 block and intermittent complete heart block. And still I did not put any temporary pacemaker. And I'm just observing the patients whether heart rate is much below and patient develops symptoms. Patient does not have any symptoms still. So I did not yet put any temporary pacemaker. Whether it is wise to put a temporary pacemaker right now.
So what is the heart rate?
Heart rate is always around 40 to 45.
And narrow QRS?
Narrow QRS, sir.
Yes. So the problem is, in this patient, temporary pacemaker will be the last resort, because this patient, you don't know how long they are going to stay in the hospital. So I think this is a fantastic decision that hold on to this until if the patient goes into long pause, significant bradycardia, you will just wait, because if you put a temporary pacemaker in, how long are you going to give? 1 week, 2 weeks, 3 weeks? So we have to wait as long as possible before doing anything like that. I think that was a good decision.
Thank you, sir.
Thank you.
Tushar, we think we should wrap up. Before that,
Yes, sir. Yes, sir.
the next, can you declare the next session will be giving out the lecture?
Sir,
Review,
you.
have you got the poster?
no, sir, she hasn't prepared that thing.
Okay.
So
Next-
there was
next
the
week.
issue of Atahar, sir, and that's why it has been kept a bit late.
I think Dr. Swadesh Chakraborty will be giving the next lecture
Yes, sir.
on
As
chamber
Atahar sir is
enlargement and
still-
hypertrophies.
Yes, sir. Exactly.
For a very basic lecture, but I think it's very important. It gives a lot of clues to underlying
if-
condition.
Yes.
Today we have again enjoyed the session very much, sir. And again, we have found out some very basic things which we need to pay attention to. Very small things, if we pay attention, then it will actually benefit not only the patient, but also ourselves by being a better doctor. Thank you, sir.
Thank you. We'll see you next week. And thanks to
Thank
all
you,
the
sir.
participants for active participation today.
Yeah,
We
today
really
they are
enjoyed your
very active.
participation. I think this is what is important for us, and that makes us feel good that we are doing something productive. Thank you.
Thank you, sir.
Rivu, thank you.
Thank you
And-
so much,
thank
sir.
And sir, credit goes to Arun Musk as well. His team is joining very actively.
Elon Musk did not say any word today.
Was
Yeah,
there,
very-
sir was there.
But
He
he was
was-
there. He was there. He is always there.
He remains
he's
present. He
here,
remains
but,
present throughout
did
the
not-
session.
Say any word. Totally silent.
Should we conclude, sir,
Thank
then?
you, Ripu. Thank you again.
Yes.
Thank you, Vaccine
Thank you.
Pharma,
Assalamu alaikum, sir.
Amrul and everyone.
Thank you, sir.
Assalamu
Thank you,
alaikum.
sir.
Assalamu alaikum and good
Good
night.
night.
Assalamu alaikum, sir. Good night.